much of the time because these subject matter experts are here today to share some of their perspectives and very practical examples of how they are addressing it within their own respective institutions and positions. And so I might start off with an introduction from each of you just very quickly in terms of what you do and the institution that you represent. Ernest, shall we start with you?
Great, thank you. Good afternoon, everyone. I'm Ernest Darkoh, co-founder of the Broadreach Group. We implement large-scale public health delivery solutions with a heavy emphasis on innovation and digital to solve the big public health challenges, primarily in Africa. More recently, we've also begun to do some work in the United States. Thank you. Nice to meet you all.
All right, let's go over to Josh.
Good afternoon, and thank you all for joining, and thank you to the government of Indonesia for hosting this terrific platform. Honored to be here. I'm, again, Josh Fink, founder of Luma Group. We focus on taking cutting-edge science and translating that science into game-changing new therapies, diagnostics, and devices to dramatically improve human health outcomes.
Thank you. Masao-san?
Hi, good afternoon. Masao Takahashi from the GAVI, the Vaccine Alliance. GAVI is an international organization based in Geneva. We work for the equitable access of the vaccines. We basically work for the low-income and middle-income countries that support providing those vaccines in the lower cost, and then try to improve the immunization higher. And that's our organization work.
Thank you. And Marc?
My name is Marc Le Menestrel. I'm a professor at INSEAD. It's a leading business school. We are based in Fontainebleau in France, in Singapore, also in Abu Dhabi. We have also a garage in San Francisco, but I teach all over the world. My specialty is decision making, and in particular, the ethical dimension of a decision.
Thanks, Marc. So let me commence by just setting a little bit of the context, I guess, of what we're wanting to discuss today. I read some stats just earlier. I'm not by no means an expert in this, which is why, of course, we wanted to bring all of you together today to discuss this. But by 2030, apparently, according to the WHO, we're going to have a shortfall of more than 10 million health workers worldwide. But it doesn't seem to be a workforce issue. It rather seems to be a system stress test. So obviously this indicates that the demand for care is rising faster than most countries' capacity to meet it. So what's going to happen here is our health systems going to change essentially by design, or are we going to have to go into crisis mode? Are we already in crisis mode before any systemic change happens? So I want to start off maybe with Ernest, because you're closest on my right, in terms of what you've seen, in terms of the kind of types of solutions that are being implemented to address this.
Yeah, so I think first, if you don't mind, I'll start with focusing on what I feel is part of the problem, right? And I think you stated it, right, is that diseases are vastly going to outstrip the capacity, the supply side capacity to address it effectively. And to me, that's actually that's the fundamental problem, is why do we have so much disease, right? Because we can talk about health systems all we want, but if we don't figure out how we turn off the tap for all this disease, almost no system is going to actually be adequate. And in general, we're in this model where the starting point is how well are we developing solutions and supply side assets to address this snowball that we're chasing from behind, as opposed to figuring out how to prevent it in the first place. And our metrics also, in terms of reward metrics, we'll say our Ministry of Health has done well because they've opened more hospitals, right? They've trained more health workers. We need more health workers to be trained, et cetera. And to me, those are failure metrics. They're not success metrics, right? So I think we need to really flip the paradigm in our minds and come up with, in fact, even with the right metrics framework of what we call success, and then work backwards from there. Say, if I actually want to be shutting down hospitals instead of opening more, then what is required? What innovations are required in order to actually implement this, right? So in terms of the kind of solutions that we're seeing, we've worked in we primarily rural, remote, most difficult places in Africa, implementing AI, digital solutions, and we've been quite successful, including doing it at really large scale. And this is with the dominant data, data being on paper, data quality issues, low capacity issues. It's possible, and we've shown it's possible to really effectively implement these modalities, and for those modalities to result in really superior health outcomes. In HIV, we have world-leading results in terms of some of the provinces and districts that we've supported achieving the UNAIDS 95 well ahead of anybody else by leveraging digital technology and innovation. We've been also building an array in terms of access to medicines, working with national regulatory agencies who sometimes have been notoriously slow at registering new medicines and devices that would benefit the population, and building an array of AI solutions for them that is radically improving their ability to speed process the introduction of some of these new modalities into countries. In some cases, literally reducing some processes that take 6 months down to 6 seconds, right? And this will mean faster availability of those modalities to support their populations. I'm on the board of the Schwab Foundation, and we work with a wide array of social entrepreneurs who have solutions that address almost every aspect of the value chain through, in essence, what are sustainable models that have been hardened in really difficult settings, and therefore could have much wider applicability. So I think the solutions are there. But what it does take, I think, is a bit of a step back and say, what do we really want to accomplish, and then work backwards from there in a very specific way to create the constellation of solutions that you need to bring to bear to address your issues. And the issues in America are very different than the issues in Botswana, which are quite different from the issues in South Africa. So it will take people with good domain expertise, good orchestration skills, and by the way, I say stellar implementation skills, because most of these things fail in implementation in order to pull this off. Thank you.
Thanks, Ernest. I mean, you mentioned a couple things there, a couple points that I want to touch upon, because Indonesia, for those of you who are familiar with our market, we are almost 300 million people. We're an archipelago of 17,000 islands, right? So we've got a connectivity challenge there. And so when you talk about things like AI and technology and how it's being utilized in a healthcare context, I mean, for a layperson like myself, it can be quite difficult to understand how these types of solutions are going to be successfully scaled and implemented in a market like Indonesia, where affordability comes first and foremost, the primary hurdle we have to get over, right? If we aren't able to deploy solutions that are affordable from a unit level to across these rural and remote communities across the entire country, how is it going to work? How have you seen it work?
Well, from my experience, affordability comes from achieving scale, right? The bigger the scale, the more it drives down the unit cost. So for example, let's take the AI platform, enterprise platform that we developed. I still had to pay for cloud utilization, I had to pay for all of these things, whether I have one customer or whether I have 1 million customers, right? If I have 1 million customers and each of them pays 1/1,000,000th of that base cost. I'm not trying to profit maximize. I'm just trying to keep the high quality services going at a sustainable business model, right? So one is making sure that you're helping whatever those solutions are achieve large scale. Second, if we take the paradigm of we're focused on keeping people well, as opposed to just focusing on figuring out solutions for when they get sick, I believe it's a lot cheaper, right? It's a lot more cost effective. I'll give an example. Pre-COVID, no doctor in South Africa would agree to, at that time it was Skype, unless they do a Skype call with me to do my consultation, right? COVID came, all of a sudden we had hard lockdown in South Africa. Now the doctors are begging to do a Skype call, right? Because it's how they make their money, right? But I noticed a very interesting dynamic. In the model where I had to go to the doctor, it was a 30-minute or an hour appointment regardless of what my need was, right? Now, all of a sudden, with a Skype call, and in particular a well visit, it's 5 minutes, right? And so in essence, they're not, half the time, they would not charge me for that check-in. And then if it was an appointment, they had to change their pricing to accommodate in a much more fractional way to accommodate the fact that I am not going to take up a whole 30 minutes of their time. And in that model, they could also see more patients, right? With the view of I'm trying to keep you well as opposed to deal with you when things get catastrophic. But in any scenario, you have to avoid the situation where the primary thing you're trying to chase and deal with is catastrophic illness, right? Because that's very expensive no matter which way you're going to slice it. And by the way, if you're doing nothing to address that, and in essence, you're letting your bucket fill up with high severity cases, then there's almost, at some point, there's almost nothing you can do. It will be expensive, and you won't be able to get around that.
So Josh, maybe I might switch over to you to maybe elaborate further on that, because I'm sure you've also, from your own organization, been able to see and be privy to these types of solutions as well, whether they're applied in an emerging market context or not. I mean, what are you seeing as like the upcoming trends, I suppose, if you want to add on to Ernest's points in terms of addressing some of these challenges?
Well, thank you. I categorically agree that we are already in a crisis, and this crisis will continue to snowball and be magnified exponentially unless we come up with solutions. And every country is different, every region is different. There's not blanket solutions, but there are a few things at a very high level that would benefit all countries around the world if they were to think about and work towards implementing. One catastrophe of the US health system, which has been adopted in many nations around the world, is a fee-for-service model. More doctors' visits, more tests, doing more, using the system more, but there is no incentivization for curing patients. You know, I come from a finance background. We like to align incentives in finance. Incentives should be aligned in healthcare. Medical providers, medical systems should be incentivized not by all the visits and not by all the tests, but for curing patients. That will result in less time in the hospital, less time in ambulatory surgical centers, and patients healed more rapidly. It's good for the patient and it's good for the system. Otherwise, it's unsustainable financially. Second, one very important thing, as much as we focus on cutting-edge new therapeutics and diagnostics, I think we need to really think about preventative health care because people shouldn't be getting sick as frequently in the first place. And preventative health care is actually very simple. You don't need to be a biologist to understand the key tenets of preventative health care. If we institute in our youth, if we make good habits in our youth around sleep, around nutrition, around exercise, around laughter and happiness, around community, we will reduce the incidence of chronic and acute diseases exponentially. So I think all people, all young people around the world need to be doing a better job to learn how to live their lives healthy. We spend so much time talking about longevity, but if we're going to be a vegetable with dementia the last 50 years of our life, is that really what we want to solve for? No, we need to institute the raw skills in the next generation to lead healthy lives, to have very good health spans in their life. Then to the extent people do get illnesses, which people still will get illnesses, I think a key component of it is early detection. In almost all diseases, chronic or acute, if you catch a disease early, your ability to cure the patient is dramatically better. The costs for the system are dramatically less. Having methods in place for early detection is extremely important. Ensuring women get mammograms, ensuring that people at the appropriate age get colonoscopies. These are really, really important to help ensure that we detect diseases early when they occur. And finally, I'll end and elaborate on a point that was made before, which is artificial intelligence. We are huge believers that artificial intelligence will help make healthcare cheaper, faster, better. Everything from drug discovery to drug development to doctor-patient interface and medical system-patient interface. But we can't kid ourselves. Biology is difficult. We think about the large language models out there today. They're very good at human language. They're very good for organized data sets. But in all of your bodies, there's trillions of data points at any given point in time. Your cells do not speak human language, and nor is it organized what's going on in your body. So artificial intelligence will revolutionize this space, help make healthcare access much, much greater. But this is a hard problem to solve and will take time and a lot of great minds working on it. And I hope we can do it in an open source fashion so that the benefits of AI applied to healthcare are distributed in an equitable manner.
Thanks, Josh. Mark, I feel like you wanna add a few things to that, but not to throw you in the spotlight there, but at least to come at it from a.
I think like it's wonderful to hear that, and it
Yeah.
shows like how Indonesia is a leading edge, you know, on these issues, and how developing countries, to some extent, they can face these problems without repeating the same behavior than most advanced countries, so that Indonesia does not get into the crisis that we have in most developed countries in 10 or 15 years, but from the start take such a leading edge approach. So I'm impressed and I like it, and I praise Indonesia for having like young people bringing new ideas for this. It's more advanced than in the Congress Hall, you know. I come from the Congress Hall. We are more leading edge in that discussion than in the Congress Hall. So I'm impressed by my co-panelist.
No, Mark, I mean, that's a very good point you make. We're sitting here on a mountaintop in Davos, and everybody here is familiar with I guess, the negative perspective on that regarding, you know, we are here with the world's elite, the most powerful, the most wealthy, the most influential. We've been talking about these issues for a very long time. Every Davos, you know, there's always the similar kinds of panels talking about the same, you know, addressing these issues, and yet 10, 15, 20 years later, we're still in a very similar spot as we were all that time ago. So, Mark, I mean, what's the answer here? I mean, what are we doing wrong so far? And maybe if you can come at it, because I think you have a unique perspective to share on the ethics part of all of this.
I teach ethics, and what was interesting in the title was the word system, like to really understand that health is a systemic issue. It's a geopolitical issue that engage different countries and exterior, interior. It engages the politics, it engages the economy, the social. It also engages the technology. It also engages the environment, because to have a walk in nature is a very good therapy to have a sense of our body, of our spiritual well-being. So it's a systemic issue, and when I prepared, I thought, well, I hope we're not going to treat that just as an economic issue, how to promote economic growth, you know, with the health system. Because if we do that, we are just doing the same thing that we have been doing in the Western world, where by promoting economic growth through health, we even and then we strive on illness. Like that's what you were saying. It's like the profound ethical dilemma is that the more people are sick, the more opportunities we have to sell drugs and to sell health services. And I remember in 2013, I was invited to do the keynote of the ethics and compliance officer of the pharmaceutical industry, you know. 350 of them, and so I gave my keynote, and my goal was to share the main dilemma, which is, I share it like that. I said, like, you have three possibilities, you know. Number one, everyone is dead. Number two, everyone is healthy and alive. Number three, everyone is alive and sick. What is the best for you? And what happened in the room, it was very shocking and profound. And what happened in the room was we talked about the most fundamental idea that health is not a commodity. And so market forces are not good enough to solve the issue of health by themselves. Does it mean that we cannot use the power of money for that? No, we can. But as a good servant, not as is a very bad master if you invest in health in a way to maximize profit. You will be part of a system with an incentive not to think, because the world is ruled by money. So it's going to push for you to make more money. So if you have more obesity, but you sell a drug against obesity, it's good, you know, it's good. So we have this sort of built-in issues, systemic issues, ideological issues that reflect in the lack of a conversation. My job, when I work with pharmaceutical companies, when I work with people at INSEAD, is to have a good conversation about that, not to hide behind the bush. And I'm very glad that here we have like the most advanced conversation I had on a panel about health, you know, and a young one with young people there. And I think it's also because it's Indonesia and it's a developing country. So to some extent, the vested interest of pharmaceutical companies that somehow, it's not a conspiracy necessarily, but they have an interest of not tackling the issue, you know, because it works like that. They say, oh, bring more money to health, and oh, put more money on health, you know. It's feeding the problem sometimes rather than solving it. So what is much needed at the first step is conscience, debate, conversation, young people, and hope also, and faith in ourselves, in our ability to use money as a very good servant, to be efficient in living the life we want.
You've met a pharmaceutical company with a conscience? This is great. Let's talk about that.
No, of course. It's like every human being source its motivation on love and on life. We are all the same. They are not like the good guys and the bad guys. They are the good guys. They are good system that allows to reveal the best in human being, and there are bad systems that are in profound crisis that tell you, please don't think about that. Please don't think about that because you're going to be a troublemaker. This is where we can do. So when I teach pharmaceutical, or when I teach military, or when I teach fossil fuel, extractive industries, I try to do it with unconditional love for people who share the same humanity and everyone, and to resist the principle, you're the bad guy. No, we are all the same, but we are prisoner of a system that is dismantling because it has reached its limits.
I love that, Marc. I mean, capital as a servant, as a catalyst, not as the master.
Not as a master.
This is something, I mean, this is a thesis we can unpack even further. And I want to move to Masao-san from the GAVI perspective. I mean, talking about capital, you know, I think you took a huge hit when certain administrations decided not to fund anymore. But I mean, how are you seeing this from your perspective, from GAVI's perspective?
Thank you. After Marc, it's very difficult to start my point. I think, but since he talked about face, I'll talk about face for the prevention, and then perhaps that I'm biased because I'm working for the vaccines. But just let me start with a little bit with the GAVI. But the GAVI is the international institution, and working for the low-income, middle-income countries. We basically, technically, simply speaking, we aggregate all the upcoming demand for the child immunization of each countries, and then we make a negotiation with the manufacturers to committing the long-term and then the big bulk of the purchases. So reducing the cost is one of the big purpose on that. By doing so, I think that we sometimes purchase those vaccines like 50 times cheaper than the market price, or 20 depending on the vaccines.
50 times.
So which means there is a public ODA funding that we can purchase like 20 times more vaccine if we manage to reduce the cost to 20 times less. but also the manufacturers. It's a vaccine manufacturing is a very capital-intensive industry that you need to have a long-term demand forecast. So that's going to be help. I mean, from the GAVI's perspective, we gain from those benefit from these processes, but also the manufacturer also gain the confidence for the investment for the necessary strengthening those manufacturing capacities and those stuff. So this is how we are ecosystem working, and the GAVI is supporting currently used to support 71 countries to currently 54 countries, which we have a graduation program. So we are not going to support eternally those countries, but our role is making sure that each country will have a kind of sustainable and then manageable and then the capability to run the immunization program by itself. Indonesia has been the champion of this context, and then this year, from the 2026, Indonesia changed the role from the GAVI-supported countries to the GAVI donor countries, so it's taking a more active role on that. In that context, doesn't mean that Indonesia has a perfect thing. There's a lot of challenges we have. So one of the things that we think that it's about design, system design, because we work with the ecosystem. So let me bring some perspective on that. One, for the ecosystem design, because one, the prevention is reducing the burden to the health systems. That's one thing that we could work on. But also that's Indonesia will be covering the kind of like 17,000 islands or something. This is like a most complex, let's say, the cold chain equipment management process we have to implement. So that's thinking of this fragile kind of like just-in-case stock building processes to the just-in-time delivery from the other way. So like we just those design thinking and principle setting of some of those ecosystems could change the game and reducing those challenges in the future. Second thing is actually as Mark mentioned about geopolitics. I think Indonesia has a biopharma, which is the largest vaccine manufacturer, so 3.5 billion doses production capacities, and also they were delivering to the 150 countries. These kind of capabilities could serve for the other part of the region and the other part of the world. That could help to build the mutual dependencies on the support for the future as well. These things help to reduce the challenges, mitigating some of the challenges that we have. And then that's what I think is quite critical. And then from the GAVI's perspective, this could be the quite win-win, because in the end of the day, from the GAVI, we had to work on not only delivering the vaccine, we had to make a vaccine to vaccination. It doesn't make sense without having this. So just that's a perspective I want to share.
Ernest, you wanted to come in with some comments?
Yeah, I think, just touching a bit also sort of on the dynamic with big pharma, et cetera. They're not the enemy, right? I always say, like, if, your kid has cancer, or if I'm having a heart attack, thank God there were innovators out there who created the modalities that will actually save our lives, or create the vaccines that we need, which, by the way, have revolutionized wellness and improved life expectancy and all of that. So we're not here to demonize the pharma industry. We actually need them really critically, because unfortunately also there is disease that needs to be addressed, and medical device and pharmaceutical companies provide the inputs that allow us to address these things. One comment I did want to make in terms of AI is often, I think, in our perspective, coming from working in the most resource-poor parts of the world, I know that there's a perspective that AI will treat the patient and augment staff, maybe one day, right? But we found much simpler use cases that have much more profound impact. For example, using AI and digital to maximize the use of your current resources, right? So many countries, I probably worked in maybe 30 or so different African countries. For the lack of resources we always complain about, it's not sometimes so much a lack of resources, but more of an uneven distribution of resources. And a lack of awareness of that unevenness of distribution of those resources that causes the problem. So many of the countries I've worked in, for example, each year, the Ministry of Health sends back money as unspent. Right? Because they're blind to where the issues really are, right? And they can't effectively resource allocate to address the things that they need to. So I'll give you one example. In a district in South Africa where we were working, we brought in big data analytics to really unpack what's going on. This was the ground zero district for HIV in the world, basically, right? Worst in the world. And this district is called Ugu district, has about 75 health facilities. When we initially engaged the district manager, they're like, I'm completely broken. I'm ground zero, I've got all this disease. If you don't give me thousands of doctors, literally, thousands of nurses, there's nothing I can do about this. But when we applied data and analytics to the situation, of those 75 facilities, 8 of them were accounting for something like 70-something% of their gap to target, right? So you don't have a 75 clinic problem, you have an 8 clinic problem. All of a sudden, I can fix 8 clinics, right? And then all the scarce resources we had, we directed them to the 8 clinics. And for example, on the key metric, which was viral load suppression, they were performing at like 36%. In less than 6 months, they went to above 90%. And this district that was the worst in the country became the very first in South Africa to hit the triple 90 targets initially. And then when they changed it to the triple 95, they were a leader in almost reaching the triple 95, right? So to give an example of there's use cases here where AI, digital, et cetera, can help in a broader, more impactful way, and then down to, for example, there is no provider. The best way is using telemedicine to provide access to that individual, et cetera, et cetera. All these other much more detailed modalities. And then one day, AI maybe being the diagnostician, which frees up, delinks it from it needing a 30-year trained human, basically, to do the job. So I think our approach is always meet countries where they're at, meet systems where they're at, and then help them to maximize what they can do within the envelopes that they currently have to the maximum extent possible. And there's an amazing amount that you can do with creativity. For example, some countries in Africa have 2 radiologists in the whole country, right? And in that particular case, I'd be like, you know what, you can buy remote radiology services from India, right, at a very affordable. So we have so much potential if we're willing to be creative, but then we lose that very rapidly when we start to think in very narrow terms.
So it's a matter of, this kind of connectivity between markets, being able to, as much as it is, localized solutions coming up from grassroots level, because understanding obviously the issues at a community level is very, very unique, right? And so you kind of need a bottom-up and a top-down approach in that sense. But you mentioned resources, and I want to ask, anyone on the panel can feel free to answer, but I read something that 20 to 30% of global health spending is essentially considered wasted every year because of inefficiencies, poor coordination, low-value care. So is it a matter, in Indonesia, we spend around 3% of our GDP on healthcare, which is one of the lowest in the world. The OECD, I think the OECD average is around 9 to 10%. So it's not a matter of us not spending enough money, but rather what we're doing with, I guess, the resources that we have dedicated to it, and then matching it with the types of solutions that are available to, accordingly. So, this is just more a comment that I would like to welcome the panel to share their perspectives on.
I'll share my thoughts. In your introduction, you mentioned that in Indonesia, there are 300 million people.
Right, yeah.
This is your most precious resource. This is who, as the government of Indonesia, you are there to support, to make sure that they're healthy, make sure they're in a great standpoint. And I think it would be, at least today, you're not going to get cutting-edge therapeutic diagnostic and tool development in Indonesia. But what Indonesia can and should be doing for its population, because data is king and we need diversity of data sets, is running trials where the safety profile of the therapy, the safety profile of the tool is low, and the efficacy could be great. You should be running the trials in Indonesia. For the biotech companies, this equates to more data. And for the population in Indonesia, this results in you being able to get free or nearly free cutting-edge new therapies and tools and diagnostics in Indonesia. Over time, this could result in a country such as Indonesia being a real hub for innovative medicine without having to spend for it and providing a better future for your population. So I think you have to embrace what you have. I think you have to embrace your people, and I think you can do it in a way that is really efficient from a capital standpoint.
Mark, did you have a comment as well to add to that? Oh, yes,
One
sorry,
quick one.
Ernest, go.
So I would maybe like to push back a little bit on the 3%.
Okay.
And say, what does that, is that 3% really based on hospitals, again, the curative side, right? Because again, this is what, going back to what we're talking about, the framework of wellness that we're talking about, right? Just to me, you then have to look at the social determinants of health and what are you actually, what is Indonesia doing related to those? Because to me, that should count as healthcare. Keeping anything that's keeping people well should count as healthcare. Education, providing education, providing, and what are they doing to do to nutritional support, safety, environment, right? Keeping the environment clean, etc. To me, that's all health. So again, if we're willing to be courageous enough to also maybe redefine what we call healthcare to include metrics that speak to some of the social determinants and what we're doing related to those, I think we'll have a better picture of what's actually being spent on health, as opposed to simply the curative side again.
Right, from a very holistic perspective. I mean, we're still very advanced diagnostic tools in AI and how these are going to be scaled across a market like ours. It feels like it's eons of time away from where we are right now. Right, and there's this huge gap from a resources perspective, from a technical know-how perspective, and a capability perspective. So it can feel really overwhelming if you're looking at this from the outside. So
I might challenge
Please
that
do.
for a second and liken healthcare for the moment to the telecommunications industry. And we saw with the adoption of mobile across various parts of Africa, various parts of the developing world, a leapfrog where we went from no connectivity to mobile connectivity. We did not stop at landline connectivity. So I actually, because I think AI will do things cheaper, faster, better, code is now increasingly being done on an open source basis, I actually think Indonesia has the potential to leapfrog the West and go straight into an AI future for healthcare. And in the process of doing so, be very advanced and do so without the legacy capital expenditure and issues and legal code of the pre-AI era. I don't think it's eons away. I think it's right in front of you, and I think it is actually the logical next step. And you can leapfrog the traditional system in the West.
sounds like a new playbook is being written as you speak. Masao-san, did you want to?
I just wanted to build up on this perspective. I think because the many countries where we are working for is actually that there are some common issues. One of the biggest challenge for the vaccine is that last mile deliveries, for instance. And then we use the drone delivery systems to testing out whether it works or not. So GAVI works with open for those innovation to create the proof of concept which works and which serves for the public services. So we do this, and we work with the investors to scaling this kind of actions in the other countries or the similar countries that we had same problems. So there's the drone delivery. One thing that I just wanted to share was to make those things happen. The technology itself doesn't help, but we need to have a little bit of the openness for the testing some of the ideas. But also there's the public institute to finance or pay for those performances. Also, it takes a little bit of the time to be accepted. So a little bit of those trial and those ecosystem to support those innovation, make it happen is crucial. But also, there's looking at from the angle from our side, for instance, we constantly work on the efficiency gain for the vaccine ecosystems, but AI, as you mentioned, and also the data that we are available, then it's much easier and it's much efficient to identify where are those zero-dose children. And the similar things can be done in Indonesia. So that's the cycle of those innovation creating the next stage of the efficiencies could be possible. But I think the starting point, if we don't have a system or the policy to back those innovation to be tested, I think that spirit and that appetite could be very important.
Mark?
Ernst, if you want, I can...
Yeah. Just a very quick intervention, because I like to be very practical. If Indonesia, for example, is at a point where Indonesia is fundamentally rethinking this model, a practical expression of that rethinking to me could be, for example, instead of moving from electronic health records, you create an electronic wellness record.
Interesting.
Right? So in this, by the way, the vaccine card is a great example. You're capturing specific wellness intervention that someone's supposed to have, but why aren't I walking around with a card saying I had my colonoscopy or et cetera, right? And I have to make sure that that is updated. And so that's what I mean by just changing, sometimes a simple thing can just change the way we think about this and result in a very different set of cascading interventions, therefore that's supported.
It's a really interesting idea. Marc?
I can maybe provide a bit of a helicopter view of what's not working and where is the solution. So what's not working is to look at the world and life as a quantity that you need to maximize or minimize. So you cannot assess your health system with a percentage of your GDP. You cannot assess the well-being of Indonesia with this GDP. You cannot, I mean, that's what we do in the global, in the Congress Center, where people come and the leaders, they come and they start saying, we need more growth, you know. No. You need more growth because you want profit for you. You know, that's, and then you make it a discourse, you know. But so, because growth, you know, can be good for some, but not necessarily bad for others. And for health, it's particularly important not to think first and foremost as a quantity. If you do like this, then you're damned. You're damned. It's not going to work. It's gonna. In fact, what you're gonna say, oh look, we have people who are sick. We spend only 3%. We need to spend more. We need to spend 5% of our GDP on health. You know, it's like in Europe. You know, oh, we have security issues. We need to spend 5% of GDP on defense. No. If we want to be safe, you know, we have to make peace. You know, it's very different. Right. You know, and so, but for the military industry, it's very different, you know. So that's the problem. The problem is a way of thinking in terms of numbers in order to make money. Money is a good servant, but a bad master. Where is the solution? It's not far away. It's not close. It's within you. It is within you. You are in Southeast Asia, one of the best sovereign funds, you know. So it is you to make sure that you don't invest in companies that are going to kill the little companies of all the new tech people who are going to be leading edge in order to maintain a dominant position. So what you need is within you, within your sovereign fund, to say, what is the vision for the country? How we, as a main source of capital, at the service of the people of Indonesia, we can have a real strategy beyond financial returns. And what does it mean? What are the values? What are the values? Where is the equity? Where is the dignity? Where is the ethics of what we are doing? So that you can use capital to support the young people in the room here and all the young people of Indonesia who are going to start from within. Well-being is from within, is to have a well-being with my family, with my entourage, with my landscape, with my island, with my tortoise, you know, and that's what matters. And this is where you can make a difference by pushing for a new form of capitalism that is more ethical and more at the service of the people.
I really love that. I think that really resonates. Merci. I think that really resonates with me in particular, but of course, you know, how then we bring it into from an institutional practice.
And I say that, I go next week, I am in Jakarta, I am in Bandung next week, you know, to take the biggest bank and to tell them exactly the same, huh? exactly. Not as strong because I need to sugarcoat a little bit, so that they can take it, But I say the same. No, this is it's 101.
Exactly.
We know it. We know it. It is just to free our mind so that we can let the heart speak. It's not big science. It's not far away.
Right.
You can do it. You have no idea how Indonesia is a role model in Southeast Asia, where you did O20 for the promoting like biodiversity, what you have been doing. You have one of the best environment minister in the world, like he's been so inspiring in the last decade. You have like so much capability. So it's within. It's within.
And I think it's just unlocking and perhaps shifting the North Star. And I think you mentioned, and this seems to be something that resonates with all of us in different ways, but the capital part, I think, really stuck with me. Capital not being a servant, rather a catalyst. Capital not being a master, but rather a servant, right? And how it serves us. And for us as a public institution, I mean, essentially, it is the people of Indonesia who we serve. And so redefining the system around values, around ethics, around wellness, and putting the people at the heart of it, not the profits, not the ROIs, but rather the people and how we can serve them. And in essence, I think Ernest, Josh, you mentioned this in your earlier comments, how we can then start moving towards being preventative, right? And providing the kind of critical building blocks that are needed so that people can make more informed decisions about their own health and are empowered in that sense. And so it becomes less a challenge or an obstacle around affordability, because all of a sudden you're not having to treat a whole variety of diseases or illnesses that they wouldn't have if they had that information, if they had been empowered in that way from the beginning.
Yeah, the way I put it is, first primary care health provider should be yourself, and that's free,
Just to jump in on the point of capital, I think it's very important, and I think if we were to look at examples of where deep capital markets lead to extreme innovation, obviously the U.S. and China come out ahead. We're sitting here in Europe, and why does Europe lag behind in so many ways? You could have an incredible mind here in Europe, but that incredible mind, he or she, very difficult for that incredible mind to get the angel money to start his or her business. Very difficult to get the venture dollars to scale his or her business. Very difficult to get the growth capital to continue the growth of that business. Very difficult to do an IPO or have an M&A, to have an exit, to funds to return that capital to their business. This is something I think the U.S. mastered very well. China has done an incredible job replicating the depth of the capital markets. And as the Sovereign Wealth Fund of Indonesia, I think thinking about the capital stack and thinking about the capital stack for companies and entrepreneurs in Indonesia from inception all the way to exit is extremely important. And only by having that depth of capital markets in Indonesia will you get that inherent innovation, not only in healthcare, but across the board.
Very nice. Sao-san, did you want to add
well, I just wanted to add one piece of this. The capital system, also those systems we inherited from the society. Inherited are obviously not perfect. And then one of the challenges that we have, one of the things we can do, and then perhaps Indonesia can do with a big market, is advanced market purchases, market mechanism. There's a failure of the market mechanisms by working, like for instance as a GAVI, that we collect those and pool those demand and then try to negotiate. Working on this, it could be using the current existing market mechanisms and also the capital systems, but still we make a small adjustment toward how we're going to be equitably distributed the wealth and also those importance of the impact that we can create. So I just wanted to share this perspective.
Thanks, Masao-san. So we have about 5 or 10 minutes left, and I wanted to, wow, lots of questions. I wanted to throw it to the audience for some questions. So maybe, if you don't mind. Yeah. I got you. I was going to give you a microphone. All right. Oh, yeah, sorry. There's someone there.
Hello. Hi, guys. Thank you so much for that talk. That was by far the best Davos panel I've seen by an absolute mile. It wasn't
We did
just
it,
sort of-
guys.
yeah, it wasn't just sort of towing the party line, saying broad statements about AI. It was very practical. It was honest. You had the ethical nature. You had the practical nature, the capital markets nature. I thought that was just absolutely brilliant. So firstly, I just want to say thank you. So I think the two main points that I took from that are firstly, prevention is going to be the key to healthcare moving forward. And secondly, we have a lot of ethically ambiguous healthcare systems across the world, not necessarily just in one place, but across the world. So a big point that I work in healthcare startups, and I noticed recently that 30% of data in the world is apparently from healthcare. And I saw from a credible source, 97% of it is not used. And I work a lot with electronic health records, and in the US specifically, in the UK, we have Epic, Oracle building these data moats around their data. And what I think is that for the future of prevention, we're going to have to use this health data, and we're not using it at the moment. So I was wondering a few things. Firstly, what, maybe from the more methodical side, what can we do to action that data? And perhaps from the ethical side, what can we do to combat these epics, these oracles that don't have the needs of the general healthcare system in their objectives? So yeah, that was my overall question. Thanks again a lot. My neck's hurting from nodding too much, so thank you.
That's great, thank you. So who wants to take that first?
We actually wrote a white paper exactly on this question, talking about the future of AI in healthcare and the biggest impediments. And the number one impediment is exactly what you pointed out, is that healthcare data around the world is highly, highly balkanized. In part, it's due to HIPAA regulation and patient regulation and confidentiality, but a lot of it is just due to self-interest. And if we don't, on a global basis, find a way to anonymize data and make that data globally available, one, we won't have nearly the same pace and rate of innovation and possibilities. But two, we also might get something that's both not as strong and not as good without as much innovation, but a few leaders that dominate the space without a dispersion of lots of leaders that are creating innovative solutions. So I think the point on data is a really important one, and probably the single greatest impediment to AI having the most profound impact on healthcare that it possibly can. Not an easy problem, but a extraordinarily important problem.
Yeah, for me, I think this is also an area that's ripe for quote-unquote constructive disruption, right? Again, going back to this kind of wellness model, right? You can disintermediate the formal data companies by, in essence, creating personal records, right, that contain critical information and ultimately will morph into will contain the medical elements, but contain other information as well, right? Because I think if we're talking about, they make money off of this data, let's be honest, right? They're not incentivized to share it and necessarily make it that open. But I think there is an opportunity to take these population-wide approaches for there to be, for example, if I have my own individual record on my phone, and there's millions of me, right? Then the power shifts back to the patient, right? So I think these are some of the things where we do need some disruption. Now, is it one company that again becomes like an Uber or a Meta that does it, or is it going to be multiple players to do it? I don't know yet, but I think this is an area that's ripe for disruption. Second, because there's really no real electronic or medical records in the public sector in Africa, there's some in the private, but in the public almost uniformly non-existent, we've been forced to focus on aggregate sort of systems level data, right? So we know how many kids were immunized, but we don't know who they are. Or how many kids were supposed to be immunized in this clinic, but we don't have their identification. But we've been able to manage and implement on that basis quite effectively, right? Because I can now drive that number to 99% if it's at 60%. Now, I may not need to know the specific kids, as long as I have good enough baseline demographic data to determine the denominator, I know the targets of who I need to reach, I can drive to that target in an anonymized basis without having to have had the electronic medical records, in terms of making sure people are getting what they need in the right place at the right time. So, so there's various levels of data. I say if you don't have that access, is maybe a step above it. That you might still be able to have good enough data that's not that sensitive to be able to act on, which is what the tactical approach we've sort of taken.
Okay, we have one question in the front here, and then the
Thanks a lot.
back.
Thank you so much. This is Mimi Chinquinones. It is such an honor and pleasure to meet the esteemed panel expert speakers here. Appointed November 2025, ambassador to the entire African continent, Pan-African Parliament of the African Union, and assigned as the senior advisor on public health and global health for Pan-African Parliament of the entire African Union, 55 countries. I want to challenge you, Ernest.
Poor Ernest. He's being targeted here.
We do not have data, 10-year look back on reimbursement and payback from any Ministry of Health. So I'd love to see where you got that data from, because there's no empirical data or research or public data available. So we gotta talk about that. Over to you. I love you. And we want to invite you, me personally, on behalf of the Pan-African Parliament. Listening to what you just said is our absolute #1 focus. It starts within you. And so at the end of March and at the beginning of September, we have our statutory sittings with every parliamentarian from the entire continent with us. And we would be delighted if you would accept our invitation to say what you just said. And what you will say in Jakarta, as soft, but to our parliamentarians.
Harder, much harder.
And to the two of yous, we are drafting a eradicate and eliminate malaria together with MMV as a legislative framework and a model law for the entire continent. And we will be motioning this for debate on the parliamentarian chamber's floor, and we'd love to invite GAVI to be a part of the expert panel. And you, my friend.
Wow, this is...
I'm in trouble.
No, you're not.
I
We
love
want to
this.
invite you as well, because what you've said is bang on, bang on. Large language models currently is a big, big topic. We're drafting a model law as well on AI, natural language processing, and quantum computing. We don't know what you know, and we'd love to invite you to our Pan-African Parliament to share your expertise across 55 countries. Thank you.
That's wonderful. So that sounds like there's some real tangible outcomes coming out after that. Sorry, I'll pass on to you, and then I haven't forgotten about you, sir, so please go ahead.
Unfortunately, I have no offers for you, so sorry about that.
Do you have an offer for me? Because I was the only one who didn't get one here.
But this question specifically for Marc, but any of you guys can answer. You've mentioned that we shouldn't measure health outcomes based on GDP. And from my understanding, that makes sense, because GDP is a measure of how much a country spends on certain aspects. And I know environmentally and in health, like just because you have a higher GDP doesn't mean like you have better health outcomes, because you could be spending like a lot of money on like diseases that's going on. That doesn't mean that you're like more healthier as a country. But another thing that made me think about, because I like just took AP Environmental Science, which is like a college course in environmental science, and I'm in high school, by the way. There's something called GGDP, where like you measure economic growth without considering like environmental degradation like GDP does. Do you think that could be used as a tool? Because from what I've learned, and you guys talked a lot about prevention, like environment and environmental degradation can really impact like the health of an individual, with like, especially with global warming, because now like there's more like areas that are like hotter and warmer that allows disease vectors such as mosquitoes to spread malaria and all sorts of diseases. And with pollution and like water and in the air, more cardiovascular diseases, more asthma. So what do you think about that? Do you think GGDP could be used as a tool or not really?
I want to first say, before you respond, you shouldn't say that you have nothing to offer, because you are sitting here in Davos and you've just, given a very powerful perspective and a question to them.
I think like this is a good example of how wise and knowledgeable and 10. I give you 10. So
we have a high school. You're in high school, right?
As a prof.
Great.
We're not going to replace a number by another number. No. The Chinese in particular, but the UNEP and many others, including even in the West, have been trying to find better measure to drive, human development. And we are looking for that, and we are still, it's still under creative mode, but in the end, it's not by aligning our life to a number that we're going to live a good life. It is by finding a harmonious middle ground with different alternatives, dynamics, in the respect of what is beyond us, and with an open heart. So whatever the number that you're going to find GDP, it will be with you, not to say, oh, this is a number, it's bad. No, you have it as a number, it helps you to be effective, and you complement it with your heart, with your values, with your emotions, with your inspiration. That is where the real shift in mindset is.
Thank you so much. Okay, sorry, you've been waiting very patiently. I know we're a little bit over time, but it feels like this is a conversation. You guys are okay? All right.
Okay.
Please.
First of all, Mimi and her family are an impossible act to follow.
Oh, it's a family affair. Okay.
It's impossible, especially after you're a hard act to follow, but then, you were followed by Mimi, so anyway. But I did want to reconcile something because I was at a session earlier where a big data company was asked, how do you bring the technology to LMICs? And the answer was effectively that the LMICs have a data set that's very valuable. You just talked about there's not empirical data from the last 10 years. And it was very interesting, based on the company that this person represented, to say that the way to bring the technology to the LMICs is by having access to that data set. So that's very interesting in terms of allowing and enabling some of this technology to that's the promise of AI, machine learning, et cetera, that you can add larger populations, and that collective data helps with better outcomes if there's ethics in the data. So I just thought that that was an interesting thing that I'd like to hear you folks reconcile, because you have people here to have that conversation, because just because the data set is available, first of all, how does that acquired ethically? Because I agree that it could be a very valuable data set because it could help the health outcomes in the LMICs. What are the ethics of that? And then there's the second part of that, which is, just because there's more data going into these models, what's the integrity of that data? And when you have an environment where there's an agenda for disproving something, the effectiveness of some of these therapies, how do you reconcile the ethics of what data goes in and how the data is used? So I know those are big questions, and we have, negative 5 minutes.
I'll answer a little. I won't answer your question fully, but I'll just touch on it, some aspects. One thing I want to say about data, the gentleman mentioned the 97, I used to say 95% is not used, so if yours is 97, I believe that. But in our experience, why do you have this situation? It's not because the data is not there, it's because we're not asking the right questions. Right, and I think, to me, what's most important, and when you mentioned that the 10-year, for example, lack of a 10-year look-back ability, is one, that data may be there. You just need to know how to get it. But more importantly, if it's not there, it's because that was not the question that was asked, and therefore that data was not gathered in a way that you can answer this question today. So if that's a really important question for you, then frame the question first, as opposed to let people randomly collect all sorts of data. And then you make sure you're collecting to answer the most powerful use case questions that you need to answer. So more of an inductive approach rather than this to how you unpack data, as opposed to this, we're going to fix the whole universe of data and then we'll be able to answer questions, right? The analogy I use is if I'm going to make a cup of tea and I'm standing on the shore of a lake, I can heat up the whole lake and then dip my teacup in, or I can take a cold cup of water and then heat that up and have my perfect cup of tea. So I think that's more the approach we need to take at the moment. In terms of access to data, this is one thing I think we need to really be careful about. Right now, a lot of the policies, and because of confidentiality, data security, et cetera, are resulting in a situation where a big company from outside Africa is going to have access to that data, but none of the social entrepreneurs or whatever have access to that data, right? Because a lot of the policies that are being put in place are actually creating obstacles to innovation for the young innovators, and this is where all the jobs are supposed to come from. Right? And we're actually cutting out the legs from a lot of these innovators because of the kind of policy framework that's falling into place. So I think we have to be really careful in terms of, I would like to see a situation where a young entrepreneur can access that country's data before a big multinational is going to come in and access that data.
Were there any questions before we wrap up? Because it seems like, yeah, this was, I must say myself, but this is, I think, my 12th Davos, and I will say that this is one of the most interesting and kind of thought-provoking panels I've been a part of, and I really, really want to thank each and every one of you for coming here and bringing such diverse and interesting perspectives, very valuable. I know my homework, thanks Mark, after this. And I'm sure all of you also have some ideas at least and some insights. Hopefully you're now able to then go home to your respective organizations, markets, and what have you, and really think about what has been said today in terms of how we work towards transforming health systems. So thank you very much to the panelists. Thank you very much to everybody. Big round of applause.
Thank you.
Thank you. Thank you so much.
Thank you so much. Thank you for having me. Thank you so much.
Thanks so much.
Very nice. Thank you so much.
I know nothing. I'm just here to thank you. You're a wonderful moderator.
Jelajahi cara baru mendapatkan informasi. Download MetroTV Extend sekarang.